At the outset, I thank Venkateshwar Manvi ma'am for bringing me here for this important CME. I was asked to talk about the rehab portion of. I think this could be more challenging than the treatment of endophthalmitis itself, because at this point of time, the patient expectations will go up. So once we know that he get rid of the infection, the next thing he will expect is a vision. I think this is more challenging, and then probably we need to look more into these details. First and foremost is the one which got lost in the end of format statement is a lens. Though lens has no role to play, not a culprit, but it is the victim all the time. We remove the lens for everything. So the first thing and foremost thing important is management of the aphakia in the endophthalmic patient. So if it is simple post-surgical endophthalmitis, quite simple way, we can choose a lens whichever we want it depending upon the capsular bag support. But it is not the case in all the time. So you may have cases in the upper corner, we have corneal scar, and you may have a corneal, degeneration or the decomposition of the cornea, or you may have a linear scars, or patient may have a post PK, especially for the ulcer-related endophthalmitis and all. So there are challenges where the patient had underwent already multiple surgeries and variable tissue loss will be there, especially the trauma, post-trauma endophthalmitis, associated corneal pathologies. IOL calculation will be extremely difficult in these kind of patients. And then we have to address even the astigmatism that will come up when you are planning for the insurance. I'll just go through a couple of cases where, so how to manage this kind of cases. This is one of the case, endophthalmitis was managed successfully, and the PK was done. Again, AGV was put. So the real challenge is how to manage these kind of cases where the IOL calculation is extremely difficult, and we don't have much entry site anywhere. Everything is sealed with the corneal scars and all those things, and we have AGV in case. These are the typical cases you may get to see in the cases. So I prefer in these cases very simple way of foldable lenses injecting into the AC and then places in a gabber like technique where I make tunnels at 3 and 9 o'clock position and a small side port to handle the lens. And you just make sure that you remove all the membranes that is adhered to the iris. A small intersite, the infro nasal part. This is very unconventional way of doing. Inject the lens, 3-piece lenses especially into the AC. Just dilate and then bring out the haptics. So the sclerotomy that is done at 3 and 9 o'clock position. This is a very simple way of managing these kind of cases. And usually the location of the lens will be a little bit posterior because we have a AGV is there and we have to keep it a little bit more posterior than the sulcus. So your measurements will be around 2 millimeters from the limbus and either 3 and o'clock position. So these cases do well, and we are not injuring the cornea over here. The corneal interface cell count will maintain as it was before. Right. Okay, next. So sometimes you may see like this, endophthalmitis was successfully managed, but landed up with corneal opacity. So these are the cases. Old is gold. Usually I prefer, open sky technique where I'll do a small scleral grooves on either side and the sclerotomies. And my plan was to do an ab externo technique of pill fixation using a 90 polypropylene sutures. So my cornea colleague has removed the cornea, and then I'm just using this 90 polypropylene on either side. Use PMMA lenses. They are very good. This is a old technique, but I do prefer in some cases when both combined PK and then the lens has to be fixed on the same sitting. These kind of lenses do wonderful in these kind of cases. The only thing we have to make sure this endophthalmitis or infection foci is not there at the time. And the usual timing is around say 3 to 6 months post treatment. So these lenses do very well in such cases as well. So sometimes you may come across post-trauma endophthalmitis where you have loss of iris tissue. And these are the cases where I would like to go for iris diaphragm lenses. They're really very good, and you can cover up the iris defect with the iris diaphragm. Again, you can go with an ab externo technique using a 90 polypropylene suture. Or if not, we can put an SFIOL over that. You can put an iris implant as well. But the problem is we don't have an iris implant available in India. And human optics, they do iris implant. They're quite costly. But this is a cheap and best one we can manage both optical as well as which can replace the defective iris as well. So sometimes these are come across a patient had endophthalmitis and then corneal tear repair done, corneal scar, extensive astigmatism. This patient had minus 4.5 astigmatism. They're quite demanding. They don't want to have spectacles with a high cylinder force. So these are the cases which do not have a back support, and we have to fix SFIOLs in this astigmatism corneas as well. So these are the cases. What I do, I use the N-Vista lenses skeletal fixation. This is a routine ab experiment technique again. You can use the 90, or you can use a Gore-Tex suture also in this kind of cases. So NVISTA lens comes with a hole at the haptic junction. You can pass the sutures through the hole, and then you can place the toric lenses exactly at the desired axis. So in this way, we can bring down the astigmatism to large extents, and this patient astigmatism came out from 4.5 to -1. The patient was happy, and then unaided vision was 612 vision. So toric lenses do come in a way where we can fix the toric lenses as SFI especially when you have a severe astigmatism post corneal tear repair, post endophthalmitis as well. So there are the few post-op images and excellent results we will get. It's not the way how it was before, where the lens placement again after multiple surgeries was a big task. Now I think we have come up with more precise techniques and then a good visualization system which can enable us to put the lenses inside. The next important thing, but as a reviewers surgeons come to get to see is refractive macular edema. So there's a case where we had uncontrolled diabetic and UTI had endogenous endophthalmitis, and he had RD as well. So we did a surgery, and then I had to resect large amount of retina because of the necrosis. So he underwent multiple surgeries and all those things. After that, macula was fine, but it's not. It never ends like that. So macula keep coming, developing macular edema. These kind of macular edemas are very, very difficult to treat. So we can use NSAIDs, steroids, and then my UI colleagues do give some interferons injections for this kind of macular edemas to settle down. And these edemas do persist for long time. So you have to take care of these edemas because that is the one reason for poor vision post end of rehabilitations. So, and so this is the one thing I found very useful, interferon. So we can use it as a topical medications, and especially for the refractive macular edemas post end ophthalmitis. So next one is vitreoretinopathies. Again, the nightmare for retina surgeons when you're operating an endophthalmitis patient. They do develop multiple episodes of vitreoretinopathies, proliferative vitreoretinopathies. This is one case where I had done a resection of the inferiorly because of the retinitis patch, but invariably he ended up in PVR changes extensive. So I think people are using intra-operative and post-operative method of exit for these kind of cases to prevent the PVR changes. And the last, hypotony is something which we don't want to see, but we do see up endophthalmitis patients. So there's one patient who had a persistent hypotony after endophthalmitis treatment, successful treatment. So this is one of the old-fashioned thing I used to do it when we have endophthalmitis. I use a silicone oil, but I put silicone oil retaining sutures. I think previously they used to use these kind of techniques to keep the oil behind the iris itself. So I use the 90 polypropylene suture to, as a barrier between the anterior chamber and the posterior chamber where the silicone oil I can inject and then I keep it behind itself. This is called silicone oil retaining sutures. We can have different designs of suturing also in this technique. This is one technique we can use it for, especially when you want to keep the eye alive without being lost for hypotony. Next, the last one is a pre-thical one. So somehow after successful surgeries and all, you'll end up like a pre-thical. But these are the cases where the ciliary body is completely shut down and the axial length is coming down. Probably this is one option we have a pre-thical eye where we have the vitreous implants like this. You can inject a silicone oil into the vitreous implant. There's a small bags which can insert into the vitreous cavity through the passband approach. Once you are inserted inside the vitreous and then you fill the bag with the silicone oil. In that way, silicone oil remains behind itself without touching the cornea, so that you don't develop in corneal decomposition. These are the last resort we can keep it when you are dealing with the pre-thical state, some of those things. Last but not least, the recurrence and endophthalmitis can recur. This one case we had successful management, but after 2 years again he came back. This time it was a fungal, previously it was a bacterial. So keep in mind these are cases which can come back with endophthalmitis after many years as well. So we have to again redo the same thing from the beginning itself. So these are the things we have to have a case-based approach in these kind of cases, and unforeseen complications do expect when you are managing the end portion of the heart. Long-term follow-up is necessary, and then adjuvant use, especially for the interferons and methotrexates, can be utilized to prevent the complications. And of course, we do have last option as a gold solvation and cosmetic rehabilitations. Thank you so much.